And the next talk will be Dr. O'Dwyer. Is it the video as well? Okay. I think discussion doesn't make sense.
So, while Mrs. O'Dwyer gets in place, probably biopsies are going to be less in the future. That's my personal thought based on all we are doing around imaging. Mrs. O'Dwyer, Dr. O'Dwyer, go ahead.
O'Dwyer, yeah, hi. My name is Elisabeth O'Dwyer. Thank you for inviting me to talk to you. I'm a radiologist. I work in Weill Cornell in New York. I work in both the abdominal pelvic imaging section and also molecular imaging. So I work both in MRI prostate and PSMA PET. So that's kind of my interest area. I have no financial disclosures. So it's kind of interesting looking at different evaluation of imaging post-IRE or post-ablative therapy. So we can see here, this is a very early, immediate, same-day MRI, where we see this big, large cavity. And then within it, we can see this T1 hyperintensity, which represents hemorrhagic or proteinuria material. And even on the early post-con imaging, we can see there's no focal enhancement within it, suggesting a treatment result. But these cavities do evolve over time. This is like a 12-month one. Sorry, I don't know why it's moving. And we can see this cavity moves down. But if you look at this throughout different fields, it looks like you see these defects, and then we see the T1 hyperintensity decreases, but the enhancement again persists not to see. And this was a treatment, no viable disease at 12 months. And as mentioned earlier in earlier talks, we have some early algorithms and proposed treatment algorithms of how we look at this. The one being most popular at the moment being PAB, which looks at diffusion-weighted imaging, DCE and T2 characteristics, with diffusion-weighted, or contrast-enhanced imaging being the most focal one. I'm not going to go too much into detail for time, and it was also discussed earlier, but has its limitations. It's based predominantly on HIFU. We don't really know the implications or potential implications from an imaging point of view of comparing thermally ablative therapies compared to things like IRE, which increase cell permeability. In other parts of the body, there is potential imaging. We put those into different buckets for different imaging ones, so there may be some differences with this. And as mentioned earlier, the PIFAB relies on T2 sequences and ADC with a high weighting, which is not ideal in a clinical setting because these often represent fibrosis and are not helpful. Target has been, this consensus document has also come up with this and also looked at DCE being the most major sequence, didn't really see any value at looking at ablative imaging before that, and also put the importance of comparing to pre-treatment MRI, looking at the grey group characteristics of the cancer, its PSA kinetics, ablative therapy performed, all the things I've mentioned ad nauseum today. So in my personal practice, I find major sequences are contrast-enhanced imaging. I think that is by far the most useful one. I also do like high B-value imaging, so not the ADC, but the high B-value imaging from diffusion-weighted imaging, and as mentioned earlier, this is especially helpful in transition zone lesions. I don't really find that the T2 or ADC are particularly helpful for a great extent, but do need to be looked at for just things like T2 shine through and things like that. So focal early enhancement being the most one. But as I mentioned previously, I am a nuclear medicine imager as well, so what is the role of PSMA PET CT? So currently it's only approved in the setting of biochemical recurrence, post-prostatectomy, post-radiation in the post-treatment setting. So the previous speaker spoke about the role of not doing a biopsy based on using PET and using MRI. Unfortunately, his points were stating things based on all pre-treatment settings. So we have to remember that a lot of the data is in a pre-treatment setting and not in a post-treatment setting. Especially in PSMA, the published data is very limited for its role. However, we do have some more experience using FTG PET, which is used in focal therapy in lung cancer, HCC, liver mets, cholangiocarcinoma. So this is just a schematic of a pattern of FTG uptake in patients who undergo RFA in lung cancer. And they described 6 different patterns, with the most suspicious patterns being, as suspected, you would suspect focal uptake or a focal uptake at the site of original tumor. Sorry. So what are the benefits of PET-CT and post-ablative imaging, in my opinion? So I think we can use it for detecting treatment response based on my clinical experience. It also is helpful for detecting pelvic and distant metastasis, which can happen in this population. And also, it is also useful for assessing the non-treated gland. And as our Australian colleagues have come up with this score, primary score. They've demonstrated that if you have focal uptake greater than 12, this is a primary 5 lesion, and this is a greater than 90% sensitivity for detection of grade group 3. However, the caveat, this is only studied in a gallium population, so this cannot be applied to F18. That's something that we need to look at for our pyrography PETs, and something that we're hopefully going to look at and hopefully have more robust data for that, because there's multiple different tracers. You have to know what you're using. So when I go back to this schematic, my thought process is there any similar patterns for PSMA PET post-ablation therapy that can be helpful for you as clinicians to determine which patients potentially need to be biopsied or which ones are the most suspicious. So looking at our data set, I went back and looked and saw if there's any particular ones and came up with some kind of interesting ones. So photopenic cavity, so this photopenic cavity here. So this is a patient who had a grade group 2 cancer, was treated with IRE, and then we can see this correlates very well to the ablation cavity on the T2-weighted imaging, no enhancement on the contrast, and no high uptake on the high B value. And this approximated very well to where the early cancer, or the original cancer was, which was PSMA avid. It's really important to look at pre-ablative imaging because oftentimes, if you don't know where the cancer was, as mentioned previously, PSMA is taken up by the normal prostate. It's overexpressed in prostate cancer, but is also taken up in normal prostate. So you need to look at the pattern. So this is what we would call a photopenic cavity, and would be compatible with non-viable disease. So second treatment response pattern is RIM enhancement, or RIM avidity. So like this area here. Again, when we look at the correlating T2, you can see this ablation cavity, and again, no enhancement on our K-trans imaging. And again, this in this case, this patient didn't have a PSMA avid lesion pre-therapy. They had a lower grade cancer, but it did approximate well to where it was on the MRI. So again, this is compatible with non-viable disease pattern. What about focal nodularity not at the site of the original tumor? So this is a video here. So you can see there's a number of findings which I'm just going to highlight. So we have primarily this photopenic area with RIM enhancements, that would be suggestive of non-viable disease, but then at the margin of it, we have another focal uptake, so that is suspicious. Again, this correlated when we looked at the MRI to an area of high B value, but no actual focal DCE, and the T2 wasn't particularly helpful. When we look at the pre-ablation MRI and PSMA, it's actually very distant to the field of where the original tumor was. So it's a little bit discordant in that setting. However, due to the focality of it, the patient went for biopsy, and this just represented post-treatment change. So I think it is important that we can get post-treatment change, like granulation tissue and things like that in that setting. They also can be avid because they're going to take up the PSMA. So it is important to look. I think the pattern, the fact that this doesn't correlate to the original site of tumor is helpful. So the third pattern would be focal nodularity at the original site of tumor, which would be suspicious for viable disease. This is a cancer. We don't actually, unfortunately, have any pre-imaging, pre-treatment imaging, but it's focal avidity left. It was a grade group 2 cancer. They had a local ablative therapy in an outside institution with a rising PSA. It had a negative biopsy outside and also only a PIRADS, what was called a PIRADS 3. So treatment algorithm wasn't even applied to it on the MRI, but there was nothing suspicious on MRI or on biopsy. When we did the PSMA PET, we can see it's focally avid within this region. Interestingly enough, on the low-dose CT, there's more focal calcification in the right gland, which is more suggestive of post-treatment change in these CTs. And this was rebiopsied, and it was grade group 2 prostate cancer, so recurrent disease. So that would be a suspicious for viable disease. And then what do we do when they have a negative PET? But suspicious MRI findings? So this is a patient, they just had this focal nodularity here. This had this focal early enhancement on the DCE with corresponding restricted diffusion actually was low on the ADC. When we look at the PET, not focally avid at all, we can see that this calcification is again representing that there was pre-treatment change but no focal avidity. There is some avidity up here looking, which actually just corresponds to radiotracer activity within the subadjacent bladder. So this was biopsied and was positive for grade group 1 prostate cancer. This patient was a retreat. It's also a lower grade cancer. Lower grade cancers are not often the higher the grade of the cancer, the more likely there are to be avid on PSMA PET, so that is a limitation within it. And then probably where it is very helpful is for nodal or distant metastasis. So this patient, it's a video, which hopefully should run, okay, had focal avidity within their gland, suspicious for recurrence, and then additional multiple avid metastasis going up into the retroperitoneum. some still images. These are all sub-centimeter short axes, would not be called suspicious by imaging characteristics alone. So that is the real utility of PET, not only in this setting, but also for your pre-treatment patients as well. So limitations, you can have, so this patient had some multiple focal imaging, so they had their pre-ablation cavity, which corresponds very nicely to, it's jumping through, which corresponds very nicely, so you have this rim enhancement with a phocopenia in the central area corresponding to where the lesion was. But they also additionally had, don't know why it's doing that, sorry. It also had, It also had this other region within the right, or the left central zone, which was on the T2 was somewhat mass-like and had some higher B signal on the B value. This was felt to be suspicious, but was rebiopsied and was benign. In retrospect, it probably was just focal central gland, which is what they spoke about on the primary score. So that's just probably physiological uptake within the ejaculatory ducts, and with the distortion of the gland post treatment, it was all focally avid on the other side, and this is finally just excreted activity within the prostatic urethra. So for me, imaging concepts for focal therapy are what are the patterns? I think the patterns of like focality at the side of the tumor are the most suspicious ones. I'm not sure if the therapy matters are segment. We don't have enough patients to look at that, but maybe there is different ones with different therapies that we use. I also like to look at what the I think you need to look at your pre-treatment imaging. That's like you have to do that. You need to look at the location of the grey group. PSA kinetics are helpful from my interpretation. I think it's not an and or, it's a both. I think it's an and, not an or. I think they need to be read together. And there may be a potential role for PSMA for equivocal findings that we could, rather than biopsying a patient, we could just do serial imaging and follow them in that respect. But we need data and we need trials to prove that, so we just don't have that data yet. At the moment, this is not currently approved in this setting, so these are all being done on trial or patient paying for them, so that's just something to consider. So thank you for listening to me, and any questions, I'm happy to take them.
Sorry. Samir?
Hi, thank you for that talk. I had a question I wanted to ask earlier to the post-ablative talk, but we didn't have time. So our experience with DCE has not been quite as robust in the post-ablative setting as perhaps what they report from Europe. It is very valuable, but we see a good number of false positives. And I think you've shown that you can see that same granulation effect in the PSMA. So my question is there an optimal timing? So in other words, if you image at 6 months, are you more susceptible to seeing inflammatory false positives on the DCE or the PSMA as opposed to 1 year? And what's your preference in that regard?
So our experience is at 12 months, but time is definitely helpful in these cases. If you look at them in other body parts, if you look at them early, you see evolution, especially depending on the type of one. So radiation, for example, gets a lot of granulation, nodular change, and that is very evolutionary. That can take up to 2 years for stability to be demonstrated. In other parts of the body, for example, liver, we look at things that being stable. They do imaging every 3 months in post-HCC, so hepatocellular carcinoma. If it's stable at a year, then that demonstrates that it would be equivocal up to a year. If it's stable at a year, then you would say it's non-viable disease. So a lot of this stuff you can get, because of the disruption of cell membranes or rest, you will get increased contrast enhancement, you will get focal avidity, but the pattern is important. Nodularity is more important than this diffuse rim component, both on PSMA and post-contrast imaging. As I said, context to where the current tumor is and versus what it is. It's also important to look at the characteristics of the tumor beforehand. If it's a hypervascular tumor beforehand, it's probably going to be hypervascular afterwards on recurrence. If your tumor wasn't hypovascular, it was hypovascular before, diffusion probably won't, or contrast enhancement probably will be less helpful because the cancer is unlikely to suddenly develop a hypervascular component within it if it wasn't ever hypervascular beforehand. So the kind of things I think about when I look at these cases.
And do you have data with serial imaging to see if some of these things change?
For prostate, no.
Yeah.
No, it's not
and what about energy source? Does the follow-up
We're not sure.
vary with cryo versus HIFU?
We have no data on that. It's all very mixed together. I think that is something we need to think about, but we have no data on that yet.
Phil?
So we're, when I say we, Louise Emmett and myself are doing a direct trial, which is a prospective trial looking at PSMA prior to biopsy for focal therapy and prior to treatment. And we did our preliminary analysis of the first 20 of those, and in the ridiculously low numbers, the PSMA PET scan did not pick up the recurrence which was picked up in biopsy, and nor did the MRI. But the biopsies that were positive were all tiny, and I presume that's why, and that's why I think probably the serial things might be useful. But so far, and that trial's ongoing and it's registered, I think that's the only way of finding out.
Yeah, I mean, like the resolution of these images is, like for PET, we're not going to see 1 millimeter recurrence.
So I suppose the question is, what's the size that you have to have for your agent, which is F18, as opposed to copper or gallium, to pick up a significant tumour?
I don't think we have, like, I don't have the data on that yet. So, but like inherently, for even the imaging, like we're looking at 3 millimeter cuts, so you're not going to. It's small. It's like probably.
So for gallium, for lymph nodes, it's 4 millimeters.
Yeah.
So you're using F18.
Predominantly, yeah.
So what's F18 in lymph nodes?
They're right, similar.
Similar.
Yeah.
Okay.
Yeah. I mean, I would, on a clinical basis, I would pick up nodes with 2-3 millimeters. But yeah.
Just a quick question.
Sure.
You presented a tissue assessment for lung carcinoma with imaging and the different options you have to biopsy or not. And you also did obviously for prostate. What is the ratio of patients that receive biopsy when you compare lung versus prostate in your experience? And do you foresee that with the tools we have now, we can eventually avoid those biopsies, at least in prostate cancer?
So I don't have the data I don't work in lung anymore, so I don't have the data for the lung biopsy rate versus, but like in liver, for example, you can.
Just to make it easier, how much do you trust your tissue assessment when you do that in lung carcinoma that is a more lethal disease?
In the biopsy setting?
Yeah.
I would trust the biopsy.
How much? A lot.
Yeah. No, I think that I am not saying that we should use imaging currently and not biopsy. I don't have that data to support that.
Right.
I think
but you feel comfortable to write down that this patient has not a recurrence when you look at lung carcinoma, and how comfortable do you feel to do the same thing in prostate cancer?
Well, I don't work in lung cancer, so I don't have that comfort level because that's not my area. But currently, if I have a patient that has a photopenic area and they have nothing suspicious on their MRI, their PSA kinetics are good, I think that I'm pretty comfortable to say that that's non-viable disease.
Excellent.
I think that it's an encompassing package. I can't look at one in isolation. You have to look at them together. It's a multidisciplinary approach. You can't, if the PSA kinetics are discordant to what the imaging is saying, then they should be getting a biopsy because
that is a great message.
That's what we don't. If it's discordant, something's not correct, and we need to look at why it's not correct because it should be concordant, in my opinion.
And then that opens the place for biopsy then.
Yeah. I think there's always going to be a place for biopsy.
Yeah.
None of these are absolutes. PSMA is not an absolute. MRI is not an absolute. So we all have our limitations. Not all cancers are going to express PSMA. So I think that if it's a discordant story, then do a biopsy. I recommend biopsies all the time.
Thank you so much. Thank you for being here. And thank you for waiting until the end.